Assalamu alaikum. The long clinical consultation day. First scenario, Mr. Ahmed. He's 62 years old, presented with lower limb swelling. Please take history, examine him, address his concerns. Ready, Dr. Ayula?
Yes, please.
Well, here you go.
Hello. Hello.
Hello. Hello.
Hi, my name is Dr. Hayola. I'm one of the doctors here today. Okay, can I confirm you're Mr. Ahmed, 62 years old?
Yes.
Okay, so I can see from my notes that you've been having some swelling on your legs. Is that right?
Yes.
Okay, can you tell me more about this?
Actually, the lower limb, actually, my left foot started to get some swelling since maybe 5 to 6 months.
Oh, let's see. And has it been getting worse since then?
Yes.
Okay, and that means your right foot is not. You said is your left right? If I get you right.
Yes, left.
So the right is fine. There's nothing on happening on the right.
Yeah, it's fine. No swellings.
Okay. Okay. Apart from your legs, is there any other part of your body that is swelling?
No, just in the foot.
It's just on the foot. Okay.
Yes.
And can I look at this leg, please? Can you show me your legs, please? Let me have a look.
Okay, just a minute.
Okay. And this leg swelling, have you noticed any change in the skin of your leg?
Yeah, it's somehow become red or something like this.
Okay. Is it painful?
No.
Does it comes and goes?
No, it's since 6 months I noticed it's increased, but no pain at all.
It's not going at all. Okay. Any rash on your foot?
No, not rash, but before I had many times that some soreness or ulcers on my foot, but no rash now.
Could you say that again? I didn't get what you said.
I said since long time, maybe 3 years, 1 year like that, I get many times sores or ulcers on my foot, but no rash.
But no rash, okay. And the ulcer
No.
still comes and goes, isn't it? Or is it always there?
Yeah, both foot.
Okay. Okay. Did you say it's painful? I didn't get that part of his history yet. Did you say the legs are painful?
Okay, I will send it now. Just wait a minute, please.
What did you say? I didn't get that, please.
I will send it, okay.
Okay. I mean, is the leg painful? The swelling, is it painful?
No.
Okay. And you said it's always there. It does not come and goes, right?
Since last 5 months, it's not come and goes. It just increased.
It's been increasing. Okay. And
I already sent to WhatsApp. Group.
All right. All right. Thank you. So have you noticed any fever?
You mean in my foot or
Anywhere in your body?
No.
Okay. And is the foot warm?
What?
The leg, is it warm? Do you know?
Yeah.
It's warm.
Yeah. I felt that swelling also. There is warm also, but
It's
no
warm.
fever.
No fever. Okay. Have you noticed lumps and bumps in your body?
No.
Okay. Any joint pain?
No.
The joint pain. Okay. And okay. Let's look at. Have you noticed? You said you've had ulcers on your feet. Does it comes and goes as well? These ulcers?
Yes, for a long time.
Okay. All right. And do you have headache, Mr. Adam Ahmed?
No.
No headache. Okay. And any issue with your vision?
No. Yeah. Actually, I start to feel like some haziness in my vision. Also for a long time, not only just now, maybe 1 year.
Okay. All right. And have you noticed any form of movement in your eyes whatsoever? Anything like that?
What? Sorry.
Have you noticed any movement in your eyes? Like maybe something is moving in your eyes, maybe like one moving in your eyes or things like that?
No.
Nothing of that. Okay. Do you any issues with swallowing?
No.
Okay. And have you had any eat or cold preference, anything like that?
No.
Okay. And okay. Any tummy pain?
No.
Okay. Any illness of your eyes?
What?
Yellowness of your eyes, anything like that?
No.
Okay. So any problem with your bowel or urine? Anything with your bowel or urine?
I think my urine little bit become fruity, something like that. But also for a long time, it's maybe 1.5 year or 1 year like this.
Okay, so you have frothy urine as well. Okay. As
Yes.
the volume reduce?
I didn't notice that.
I didn't notice that. Okay. Okay. So are you aware of your heartbeats?
No.
Okay.
But I have like chest pain for months, and I went to my GP, and he just prescribed me an aspirin, and I'm now on aspirin, but not just comes and goes, this pain,
The pain, okay.
and relieved within minutes. So I'm not worried about it. I already take aspirin now.
Okay, tell me about this chest pain. How is it like?
If I do something more than ordinary, I used to, I walk long distance, or I just go upstairs, or I feel that I have like some tightness in my chest. And I went to my GP, and he just prescribed me aspirin. It's like about 7 months now, and I'm now on aspirin.
Okay, all right. And has that been helping you with the pain?
Not that much actually, but the pain relieved within minutes. That's why I'm not worried.
Okay, all right. And do you notice that when you lie down, you have shortness of breath when you lie down?
No.
It's not such. Okay, all right. Thank you. So could you tell me how you manage for any medical condition?
Yes, actually, I have high blood sugar since around 10 years, and also high blood pressure
Okay.
since around maybe 8 years.
Mm.
And also, my GP said I have just also high cholesterol and give me some tablets for that cholesterol also.
Okay, I see. And are this controlled? The blood pressure, the lipids, are they controlled?
I don't know. I didn't go to clinic to follow every time. They said come, but I don't want to go hospital many times. That's why
Okay, I
I
see.
didn't check.
Mr. Hamed, at this point, I just want to say that it's quite important that we follow up on you with this blood pressure and the blood glucose reading, so that it can be known if it's well controlled and your medication can be adjusted appropriately. So I would advise you to keep with your appointment with the GP. Okay? Are you on any treatment for this hypertension and diabetes and lipids? Any
Yes,
medication
actually,
whatsoever?
I have a lot of medicine. That's why I don't like to go hospital many times, because every time I went, they give me another medication. And now I'm in insulin, multiple doses every day, and this is make me in trouble. Actually, I don't like to inject myself many times.
Okay.
And also, they also prescribed me for high blood pressure medication, maybe called lisinopril or something. And also, I get aspirin lately, and I have, I think, atorvastatin for cholesterol.
Okay. All right. Let's see. So, okay. So, what do you do for a job, Mr. Hamed?
Now I'm retired, but before I used to work as a teacher.
As teacher. Okay. Why do you retire? 65. Okay. All right. Okay. What do you drive, Mr. Hamed?
Yes, I'm driving.
You drive. Okay. I think you at this point, because of the vision thing that you said you have, I think it's important that you may need to stop driving for now. Okay.
Why? Because okay, I have swelling and it's since long time and no pain. I can drive. It's okay.
Okay, all right. It's because of your vision. Okay, so do you have any allergy?
Allergy? No, I
Okay,
didn't notice.
any surgery in the past?
No.
Any alcohol?
Yes, but within limits.
Within limit. Okay, do you smoke cigarettes?
Yes.
Okay, how many stick and how long have you smoking for?
It's a lot, about 8 to 9 per day.
8 to 9 per day. Okay, and how long have you been smoking for?
What?
How long have you been smoking?
Since I was young, maybe 40 years like this.
Okay, Mr. Hamed, it's important. Have you ever considered to stop smoking?
Actually, I tried, but I don't know, I couldn't.
Okay, yeah, we could look into helping you, okay? So it's
Okay.
better that you stop smoking, and we could refer you to a cessation clinic, I mean smoking cessation clinic, okay? So that you
Okay,
can
thank
find
you.
some help. All right. So
Okay, thank you.
how has this affected you?
What?
How has this condition affected you? I mean, in terms of your activity, daily
I,
activities.
not that much actually, because it's since months and it doesn't cause me any pain or hurt. But actually, I'm afraid because I have a friend with the history also of high blood sugar, and he
Mhm.
has some foot problem and ended with cutting his leg. That's why I came to her to.
Oh,
I don't want to
Hatsi.
cut my hand.
Oh, Hatsi, that must be really distressing for you. But not to worry. We would let me examine you first, and then we can discuss about this. Okay. So
Okay, okay.
first, I want to look at this you generally to see if there's anything obvious, any rash in the body. Are you pale? Is there pallor? Then I want to check this.
Not
No
not
pallor.
obvious color, no color,
No
not
pallor. So
obvious.
I want to check the legs of your leg as well. To look at it
Okay.
from the look at it down. Any ulcer currently? Then
No, no ulcer.
no ulcer.
No ulcer, no.
I want to
No.
check in between your foot. Any
Okay.
ulcer in between the foot, and then next I want to check for sensation quickly.
No, before between the foot, yeah, there is the right foot has between the small and the fourth finger toes.
Okay.
Sorry.
Okay, Hatsi. So I want to check your sensory in this leg. Any lot of sensory in the legs?
What leg you want?
Both foot. Sensory loss in both foot.
And you will check it as dermatome or like
What do you
sensory
say?
level.
What do you? I didn't get
You
that.
you will check it as sensory level or what?
I'm checking for sensory testing, the pain, temperature, joint
Nothing.
position, sense. They are
Negative for
intact.
pain.
They are intact. Okay. All right. Good. So what's the
Negative.
blood pressure, the pulse rate of this patient, cardiovascular examination as well for her, and then I also want to check for pronator drift in this patient. Okay.
You will
And
what?
pronator drift for her, for him rather.
Ah, no, nothing.
Pronator
Negative.
pronator drift. Okay, and then check the high. So check the high. For any also quickly check the high. And can you see me well? Can you look at the visual acuity? Then do the ophthalmoplegia. Then the reflexes, and then check the back of the eyes. Okay. Any findings?
Okay. Yeah, there is by fundoscopy you will see you will found some retinopathy
Okay.
as a hemorrhagic and cotton wool.
All right, that's it. So thank you for allowing me to examine you today. Mr. Hamid, do you have any concern? Okay. Any other concern apart from what you told me earlier?
Yes, I just asked you before. Are you going to cut my foot?
Yeah,
I'm just
Mr.
worried about that.
Yeah, it's a good thing that you've come to us today, Mr. Hamid, and I put note of everything that we've discussed together. I think you might be having some complications from the background things that you had, the hypertension, the diabetes, and the lipids, which may also be the reason why you are having the heart problem. But about cutting your leg, the first thing you want to do is to first assess it thoroughly, do some tests, like from scan of the leg to see how well blood is supplied to your legs. And then we can take it off from there, invite the specialist to come and have a look at you, and then we can discuss from there the
Uh,
management that are available for you. Okay.
2 minutes left.
so what's possible not to cut my what possible treatment you may give me not to cutting my foot?
Okay. For the first thing, first thing we need to do is to first assess you holistically, check your glucose level, your blood pressure, do heart tracing for you. Okay, and also check your kidney function by urine dip, which I will do for you before you go. I mean today. Then for your legs, what we are going to things that we are going to do first, like I said, we'll check for how well blood is supplied to this leg because blood supply to this leg, and then we have options of things that we can do for you. Okay. And that will include controlling your blood. If all these are found to be high, then we need to optimize you clinically first, and then we can consider Well, it depends on how bad this leg is when we do the test for you, okay? Possibly we may be able to take it off, but right now I'm not able to tell you if we will cut the legs or not. It's a difficult decision to make in this room, except we do further investigation for you. All right?
Okay, thank you. Will you admit me?
Oh, sure,
The hospital?
definitely. Yeah, I want to admit you, but first, I want to admit you in the hospital because of this leg, and also to optimize you generally. And would do, yeah, I want to admit you, Mr. Hamid. Is it something you want to consider? Do you want to do?
Okay, thank you.
You're welcome. Thank you.
Okay, time is up. Examiner questions. Dr. Sarah, please.
Please present your case.
Okay, I just examined, just spoke to Mr. 65-year-old man who presented with unilateral leg swelling, which has been there for, on the right, who's been there for about 5 months, with previous history of recurrent ulcers in the leg. This leg I've been getting worsened. I've been getting worsening. Other possible findings on history include brain of vision, also has repeated chest pain, which is worsening on exertion and relieved with the use of aspirin. And then also had floodiness of urine as well. Is a known patient with hypertension, diabetes, and also elevated lipid, elevated cholesterol, who is not regular with hospital follow-up. Apart from these, there's no other significant findings in the history. Apart from that, he also smokes cigarettes. Examination wise, there's unilateral leg swelling with change in discoloration. There's no there is no loss of sensation in the foot, pulse rate, and the blood
No,
pressure.
I said it's loss of sensation. I didn't say not change. Lost.
Okay, I thought I had negative, sorry. So there's lots of sensation, which I would have loved to check if it's in a glove and stocking pattern. And also the blood pressure, I also check for the pulse rate and the cardiovascular assessment in this patient. So putting all of this together, I'm suspecting that the patient could be suffering from diabetic foot syndrome, diabetic foot syndrome, or possibly with diabetics with type 2 diabetes with microvascular complication, which may include the foot syndrome, also the angina that is having, diabetes, also the floodiness of urine, which will be the diabetic nephropathy, as well as retinopathy. Other things I want to include consider in this patient would be chronic vascular insufficiency, that there may be a possibility in this patient. Other thing I want to consider would be a cellulitis as well. Thank you.
What do you mean by diabetic foot syndrome? Be more specific, please.
Okay, I'm thinking a patient has diabetic foot syndrome, possibly the diabetic foot disease. Is anything else?
Yeah, what? Mean
Is that
infection?
is that what?
She mean what the cause? What the
explain
cause?
what's
Yes.
the cause.
Okay, I'm thinking it would be of a mix of a vascular neurological. Is it the neurological cause?
Okay.
You answer. What possible? What possible? What the possible cause of diabetic septic foot in this patient?
It will be possibly in neurology of a no, it could be a vascular origin. Is that what you mean? Is that a vascular or neurological origin? Neuropathy?
So
neuropathy?
your first differential, it's vascular?
Yes. No, vascular. No, neuropathy, then vascular. I'll think of neuropathy first in this patient.
So you mean it's diabetic neuropathy?
Yes.
This is your first differential.
Yes.
And it will cause swelling?
Okay, unilateral leg swelling. No, not possibly. Not possibly. Possibly, I'll think of
okay. Other differential, please.
I'll think of a chronic vascular insufficiency.
Okay, this is first or second?
So what? They will be the first differential. Sorry. Then the diabetic neuropathy.
Okay, what else?
Then cellulitis is a possibility in him. Then a chronic deep vein thrombosis, possibly a deep vein thrombosis as well, will be a differential in the patient.
DVT will be cause swelling in
Yes.
foot or in the leg?
Is that what?
The swelling of DVT will be
Yes,
in
DVT
foot per se
in the
only?
legs.
No. Did you check the leg? Did you check the thigh
Yes, I checked the leg and the foot as well.
and the thigh?
No, I didn't check the thigh.
And the leg there is swelling in the leg?
Okay.
There is a swelling in the leg?
Yes, it is
It's just
swelling.
no, it's in the foot only, not in the leg.
Not in the leg. Okay, all right. I think that was where I mixed it up.
Okay. Plan for this patient.
Hmm?
Plan for this patient.
Okay,
How are you going to manage this patient?
Okay, for this patient, first I want to advise the patient on the need for hospital admission, and then I also want to do a Doppler. Want to do cardiovascular assessment for him. Do the HbA1c, lipid profile, also the lipid profile as well. The full blood count, and eventually urea and creatinine for him. Then other things I want to do will include a Doppler scan of the legs, of both legs, to assess for the vascular to assess for the vessels of the leg, and then then do a urine dip for him as well. Then a clotting profile test will also be important in this patient. Other investigation I want to do will include an ECG, echocardiography, echocardiogram as well. Then yes, that's how I would have loved to investigate this patient.
Okay, how to treat this patient?
Management of this patient will be a multidisciplinary team approach for him, and I want to involve the endocrinologist. I want to include the specialist nurses as well. His GP will also be involved in his care. The counselor as well. The pediatrics in his care. Then first is to assess, stabilize his cardiovascular risk, control his blood pressure, control diabetic, and also place him on lipid profile, on statins. And then for the legs, is this is a digit ulcers in between the digit. I want to take a swab, do MCS, and also comment on antibiotics if this is appropriate for him, and invite
Swab, please. Swab from where?
in
You
the
will get
in the
swab from
foot. In the foot. So they said there's an ulcer in between the digits, isn't it?
from the okay.
Yes, I'm going to take a swab from the
But
digit.
it's in the right foot, not in the left, not in the swelling foot. Okay.
Okay.
But you will go swab from there, yeah?
Yes, I'll do a swab from the foot.
Okay. Thank you, doctor.
Okay, and then then invite the vascular surgeons to assess as well as general surgeons to assess this patient. Or other then counseling on foot care will be important. Then ophthalmology review for him, nephrologists will also be involved in his management. That's a lot I want to manage him.
Okay, thank you, doctor.
You're welcome.
Okay, thank you, Dr. Ayula. Dr. Sarah will comment, then I will comment.
Okay, doctor, thank you and well done. This patient is a 62 years old male, known case of diabetic and hypertension and high cholesterol and hypercholesterolemia. His with history shows that he is not compliant with his medication. He is not going for follow-up visit. He is uncooperative even. This swelling started since 6 months, doctor. Why you will admit now? And if it's something like blood vessels obstruction or thrombosis or DVT or whatever the cause in blood vessels, it will be acute, not like 6 months and painless and if you said it's because of vascular insufficiency, it will be painful, and there is signs and symptoms of ischemia, even acute or chronic ischemia. You didn't notice any wasting, you didn't notice any loss of hair, shining of skin. This is all sign and symptoms of ischemia. But in this patient, nothing of this, just only foot swelling, okay? So this case is a Charcot erythropathy due to neuropathy, not due to blood vessels insufficiency, okay? And it's still in the, Charcot erythropathy or Charcot joint takes maybe years to get the deformity. So at the beginning, maybe he will just come with little painless swelling, okay? So the first differential must be the Charcot joint, not insufficiency. Yeah, you can see blood vessels insufficiency, or but make it fourth, fifth differential, because there is no sign of ischemia. Yeah, there is heart chest pain, and it goes with ischemia of the heart, but this is because he is not compliant with his medication, and he has a lot of complications of diabetic. Okay. But here the case is for joint, not for the blood insufficiency. You missed something, doctor. After grading, you didn't just ask me if after introducing yourself, and you just please ask me. I wanna ask you, and then examine you. Is that okay with you? But you are already start to without any permission from me. Okay. This is at the beginning. I think fever jargon. I'm not sure, but you used to say for a fever and ask more than one time about this. Regarding the history, you must diabetic history. Diabetic history is very long, and patient came with a lot of complication. You should be more to take more details about this history, okay? If you have any diabetic patient, especially if this patient long duration, non-compliance with his medication, and so on, you should take more details history about diabetic. You can start with asking the patient for how long you are having this disease, and show me please your medication list, and you can ask about each one in details. If there is any change dose added or new one medication, are you compliant or not, and why? I already told you that I couldn't use the insulin because of multiple doses insulin, and I don't like to inject myself many times. Ask about diet also, if he do exercise or no, and his last blood sugar reading, HbA1c last time, when it was, and the reading was what. Okay, and then you should ask about all the complications of diabetic, even micro or macro. If micro, you can ask about visual, and you did. If there is any frothy urine, and you did. And if there is neuropathy, pins, needles, tingling, numbness, and so on. And macro also, you can ask about history of stroke, for example, history of MI or atherosclerotic syndrome. I already informed you that I have chest pain, and this is signs of macro. A complication, okay? You didn't ask me at all about the neuropathy history at all. You didn't ask about if I have gastroparesis symptoms. You didn't ask about just you ask about the sensation while examination, but you should ask in the history also, okay? Because you are dealing with patients with diabetic history for a long time, okay? Also, you didn't ask about the past history in details, just what medical. You didn't ask about, I think, surgical, did you?
About what?
Sure. Surgery.
Yes, I did.
History,
I did.
Okay. Family history, you didn't ask?
Family history. Yes, I did have family history.
You asked? Okay, sorry. When examination the patient, okay, you can start as general examination as usual. Start from hand, face, and go down, or you can start directly from foot and then again general. General examination, as you did, from hand, see, and pulse, and blood pressure, offer at least supine and standing, because if there is autonomic neuropathy in this patient, And as you did for visual problem, eye examination, and you should auscultate heart. If you have time, you can do cardiovascular in details, because patient also came with chest pain, but it's difficult, I know, to do all. Auscultation is enough, as you did. And the lower limb or this swelling, you should do examination in details, doctor, okay? You should do inspection, palpation, CNS examination for this foot. By inspection, you can notice there is a swelling with erythema. If there is deformity or no, you should check if there is ulcers, both foot. Even in the heels, sometimes there is ulcer in the heels because of neuropathy. This is the compression areas, heels, and the dorsal of the foot. Palpation, you should check temperature and compare it if there is tenderness or no tenderness, because there is no pain. So, but also you should ask the patient, I will just please compress here. If you feel pain, please inform me, and he will not feel pain. Check also pulses. This is most important. You should check pulses, lower limbs and even upper limb, but lower limbs in detail, dorsalis medius and the posterior tibia, okay? Both legs, both foot, okay? You check the legs, if there is swelling, there is wasting, there is sign and of ischemia, but you didn't, but must be, okay? And you can just move the joint itself or the foot itself. Ask him, there is no pain. He said no, and then okay, I will move it. If and see, you can if in the stage of Charcot, maybe there is crepitus and you can feel it. Okay. And then you should do the CNS examination for lower limbs as for neuropathy. Okay. You will do tone, power, and reflexes, absent ankle reflex for sure. And you will do the sensation, all the modalities, doctor, not only the pain. You should do pain, all deep and superficial sensation. Okay, you didn't do the proprioception. You didn't do the vibration, just pain. No, you should. While there is case of neuropathy, you should all the modalities should be examined. Okay, and just to which side it becomes, it's under, it's just to the level of the ankle, if it's the mid of the leg, up to knee or to where, because we know it's stock and gloves appearance of neuropathy, okay? Regarding to investigation, beside the basic investigation for sure, doctor, I want to ask you one question. From basic investigation, what investigation you want exactly to do?
What
must be done. Basic investigation, the usual investigation. What investigation exactly you want to do it? Must be done.
Must be done in this patient?
Yeah, from basic investigation, usual investigation we did for all patients.
Yeah, you would do the routine, basic investigation, the full blood count, then you want to check the HbA1c, electrolyte urine creatinine, lipid profile. Then, yeah, you urine deep as well for him. Any other thing that we need?
Yeah, okay. And your differential was cellulitis, doctor. You should do CRB and ESR also because it's inflammatory marker and should be done. Yeah, should be done because it's strong differential for this patient, cellulitis, okay? And for specific for this patient, as a Charcot joint, what you will do for this patient? You before mentioned as it's vascular insufficiency, but now you know it's Charcot joint. What you will do specific for this patient?
You want to do X-ray?
Okay.
Of the foot?
Yes.
Yeah, and also consider giving him some painkiller. Since he has pain, if he has pain right now.
No investigation. I mean, here we are still investigations, specific for investigation for Charcot.
Yeah, you want to do
X-ray. Yeah, good. This is the initial. Yeah.
Yeah, and then possibly you also want to do possibly an MRI of the foot if that's.
Yes. This is the best. because X-ray at the early stages, maybe now this patient just for months, maybe it will show nothing. Okay, so the best is MRI. Okay, also some doctors offer isotope scanning because to differentiate from other causes like osteomyelitis, because also osteomyelitis has strong differential here. Okay, and the management, you said yeah, painkiller. What else?
Management of charcoal, we want to give painkillers, then educate the patient on the diagnosis, and then
Doctor,
I said
I want to ask you, you
educate.
think painkiller will be logic here? Patient has no pain. He said, I'm just worried about they may cut my foot.
Okay, you just want to reassure him that it's not that first causing of the foot may not be one of the things that we are considering now, but you want to invite you want to do a pediatric referral for him, and also the
Yeah.
orthotic referral so that he can have a look at his leg and appropriate
Okay.
shoes, appropriate modification that can be done for him. Yeah, orthotic referral basically for him.
Okay. So for definition of this patient, as you said, we can do the possibility of vascular insufficiency, but it's not at the beginning. Just make it force like this. At the beginning, you can spot the Charcot joint, as we said. Second differential osteomyelitis, strong differential, diabetic uncontrolled, and maybe it will take 6 months. But against this, also there is no fever, no sign of infection. Also cellulitis and diabetic foot. Again, against this, it's not acute case and there is no fever, patient not toxic, and so infection also can as differential only. Fourth differential, we can get acute gouty arthritis, attack of gouty arthritis. And as you said, peripheral vascular insufficiency diseases. This is also differential, but because there is no sign of ischemia, it's a little bit at the bottom of the differential, okay? And for management, just make it like this: non-pharmacological and pharmacological. Non-pharmacological, patient education, counseling, and offer, if need, the social or occupational support according. And should encourage for diabetic control of RBS and offer dietitian and also for him, because he said I can't use the insulin because of multiple doses. You can just inform, maybe you can get you insulin pump to solve this. Regarding the pharmacological, the main treatment for Charcot is the foot fixation. Okay, non-weight bearing fixation cast. It will just put in there for 3 to 6 months. Also, some may offer bisphosphonate if there is destruction or the deformity of the joint. Okay, but in the severe and late stage, we can send for surgery. Okay, that's all.
Okay.
We can send for what, Dr. Sarah?
Surgery.
Surgery. Okay.
Okay.
Don't forget the orthosis. Special
Yeah, ortho,
shoes.
I mean.
Yeah, special shoes. Sorry, you mentioned, right?
That what the orthotic would do for him.
Yeah.
Special. Yeah.
Okay, thank you, Dr. Sarah. Good explanation about the whole condition. But I will ask either you or Dr. Ayula, what are the differential of Charcot joint?
Okay.
Apart from swelling, Charcot joint causes or differential?
You mean the cause of
causes.
neuropathy?
Yes.
Yeah, cause the most common
Okay.
cause is diabetic for sure, diabetes mellitus, leprosy, and syphilis, but tips dorsalis, alcohol for sure, and also maybe any cause for neuropathy like rheumatoid arthritis, laryngomyelia, and any cause.
Okay.
Yeah, and
Understood.
Charcot Maris too can also have Charcot joint as well.
Perfect.
Yeah, because
both
it's a mixed motor neuron. Okay.
Yes. Okay, this is the last question. I think Dr. Sarah covered all topic regarding Charcot joint. Don't forget the image here is very important. Chest X-ray, started by X-ray, followed by, if no conclusion, MRI to rule out osteomyelitis. Yeah, I agree with the comment regarding history or blood sugar control. The old diabetic history, Dr. Ayula missed. either the macro or micro, even the low or hypoglycemia. She didn't ask. The hemoglobin A1C.
I asked if she's following up and she's having the blood test done. She said no. I asked all of those. Then I think I got the macrovascular, the angina, the retinopathy, the nephropathy. Those are the things I asked the patient.
It's okay.
Yeah.
Yeah, but again, try to analyze more because it's mostly related to diabetes. Actually, initially, when I heard about ulcers
Mm.
and chest pain and swelling, I suspect like, but he's not young to say this. He's elderly, so you cannot say this is based, for example, phlebitis complicating DVT or DVT complicated thrombophlebitis. But again, the level is very important, Dr. Ayula. You have to know the extent of the swelling. Is it
Okay.
ankle level or higher or thigh? Even you can offer tape to measure if you
Okay.
have above the ankle level swelling or edema.
Mm-hmm.
Measure it.
Mm.
Compare in comparison with the other side. Because you might have TVT as venous insufficiency, as you mentioned. Possibly, those patients they have three types of edema or insufficiency: the venous, the arterial, and the nervous or the neurological. All of them, diabetes patient or diabetic patient, unlucky having all of them, right? So even the ulcer, you have to examine if there is any socks you can remove. You might have one ulcer either at the tip as ischemic one or vascular one or a neuropathic one at the medial malleolus side for the venous one. And the third is arterial. So all of them, it might be in this patient. At the soul, you can have also the neuropathic one, which is due to ulcer after trauma. You have to ask about trauma. I don't know if you asked about trauma or no. It's
No,
very
she
important.
didn't. She
She did.
didn't.
Okay.
Doctor, about ulcer, it's ulcer in the foot itself.
Yes.
So
Yes.
Bahjat is far away differential also.
Yeah. Initially, I said before
Oh,
mentioning the other complication and the level, even it's not the level of DVT. DVT usually higher than the ankle. Okay. The other thing here, most important, trauma. Yes, I stress on this because charcot joint usually start by trauma. Okay. Even the diabetic septic foot, as put in the differential, started by trauma, simple trauma or minor trauma, and the patient neglect or he even couldn't feel it, and it again later on become an ulcer, and with the vascular insufficiency, this ulcer become bigger and bigger, and of course, with poorly controlled diabetes, it will not heal, and the patient will have diabetic septic foot, which end up with amputation.
yes.
That's why
Yes.
he's worried about amputation, because most of them end by amputation. But charcot joint, sometimes it can be survival longer with some rehabilitation, with cast, with the shoes. All this support can help to be longer. But the diabetic septic foot, unfortunately, whenever there is injury or wound, it will worse and deteriorate day after day, particularly if there is ischemic manifestation or ischemic insufficiency, the wound will be worse. Okay. Anyone or Dr. Sarah first and Dr. Ayur, any comment you want to add? We
No,
already,
thank you.
yeah. Dr. Sarah, I will, your scenario. You can see it in the chat box. 65 years old Mr. James Anderson, present with fatigue. Take history, examine the patient, address his concern. Now we will open the discussion. Anyone want to add any comment? Want to say anything regarding Charcot joint, the history? Okay. Diabetic septic foot. Yes, it's not DMF. It's DS, diabetic septic foot only. Dr. Henry, diabetic septic foot, peripheral artery disease, trauma, vasculitis. Okay, so sorry for the interruption. The scenario, okay. Differential of foot swelling, Dr. Gabriel. Charcot joint, perfect. I think he's the one wrote it. No one else wrote it. No one expected the Charcot joint. However, the picture is not conclusive, really. It's and the level also is not helping, and the deformity is not there. So you cannot expect this is
It's
Charcot
early,
joint.
doctor, just for months. That's why it's
Oh,
still
okay.
just swelling and
Yeah,
hotness, and
exactly.
that's
So
it.
no deformity. The most eventually most of the Charcot joint they will have deformity. Okay, so Dr. Henry, I think no, Dr. Gabriel, he the only one wrote for Charcot joint, septic arthritis, cellulitis, and gout. Perfect differential for ankle or foot swelling, unilateral, of course. We are not talking about bilateral. Diabetic hypertension, nephropathy, diabetic hypertension, retinopathy, ischemic heart disease. Perfect. So he mentioned all the complication which this patient is having. A good point, Dr. Ayula addressed the concern of driving. It's very important. As long as the patient is having blurry vision, you should advise him to stop driving. Whatever he is able to see, he should be checked before giving or before he's having the license. Okay.
the excellent point with Dr. Ayola that I asked when she advised to stop driving. I asked why I can drive with my foot, it's not causing pain. But she insists because of vision, and this is excellent actually.
Yes, this is for the welfare, for the safety. You have to stop him. It's a retinopathy issue, not only peripheral neuropathy. Even the peripheral neuropathy, it can uh, stop him from driving because he cannot feel the sole. Anyway, at least stop him driving. And the most concerning part is the vision. Okay. Cast and immobilization. Yeah, this is the main or the cornerstone of the management. Cast or immobilization. And after that, he can have his shoes, s- specific shoes for the charcoal joint. Okay. Anyone want to comment apart from the comments? Yeah, again, Dr. Henry, he wrote for bilateral or before he expected it's unilateral. This is the differential for bilateral edema. Good differential, Dr. Henry. CKD, CCF, I think he means CKD, chronic liver disease, DVT, DVT unilateral, filariasis, yes, cellulitis unilateral, drug-induced, likely angioedema, yes, amlodipine, or even angioedema type, bilateral. But you mean ankle for amlodipine, okay, calcium channel. Malabsorption, you mean as protein losing, enteropathy. So the patient will have also the same picture of nephrotic syndrome. What is CCF? CCF.
Congestive cardiac failure.
Oh, okay. Congestive cardiac failure. Okay. Yeah, the same. So any failure can cause bilateral edema.
Mm. Actually, when initially I put down what my differential list was more of bilateral
Yeah.
edema. Then I put the DVT. Bechet was in there. Even I put in filariasis because at the point when he said she has some issues with the side, so and the legs, I was like, okay, could it be something to do with filariasis and things like that? So those were the differentials I put down here for him. But just a quick question. I'm sorry to cut you short. I'm so sorry to cut in. Um, could the diabetic foot syndrome will it be something that could fly? Because if you're not quite sure which of these diabetic, foot issues that is there, is would it be a good thing to cover it with the diabetic foot syndrome umbrella thing, and then possibly talk about the other differentials as well?
Okay. What do you mean? That's why I ask you also myself. What is the cause of diabetic septic foot in this patient? You have to mention, and you have to have risk factor. You didn't
Mm.
ask about trauma to say this is after trauma, right?
Mm-hmm.
Mostly, and most patients with diabetic septic
My God.
foot started after a wound injury. right? So if you don't ask about injury or trauma, how you can say this is diabetic septic foot? Yes, it could be, but even you didn't roll it out from the history taking. You got it. So yeah, you can see cellulitis because it can happen without want. But here, if you want to mention diabetic septic foot, you have to have wound or risk precipitating factor that this patient is already had infection because of this wound. You got it.
Yes.
Okay.
Yeah.
Yeah, that's why mostly or usually the diabetic septic foot happen after a wound, and to prove that, you should take a history of trauma or injury or wound at least, which you miss already. So I agree to mention it, but you have to say based on, right? So I will say this is diabetic septic foot based on, for example, peripheral neuropathy, and the patient maybe hurted himself without feeling. Later on, he had a wound, then the wound infected, and so on, and complicated by diabetic septic foot. Or you can say there was ischemia, and the ischemia developed an ulcer, heel ulcer, for example, or big two ulcer, and again complicated by diabetic septic foot. So you have three pathology, either trauma and neuropathic cause, or vascular arterial one, and he has wound and the wound complicated, or even the venous itself might have a venous ulcer. Again, it will complicate and infected, and to be complicated by diabetic septic foot. All of them can give. So you have to give an evidence, okay? Which you miss. I think you just put it as an umbrella, but you didn't explain, and you didn't say what risk factor this patient had earlier to have this diabetic septic foot. You have to explain it, either by history taking or during the discussion with the examiner. I hope you got my point, Dr. Ayla. Are you? Does it make sense for you?
Yeah, it does.
Okay. So you can say it, or you can say something infection from inside, like stomatitis, for example, or cellulitis. Okay. So these are the three differential of swelling: cellulitis, stomatitis, and diabetic septic foot, based on, for example, post-infection or post-trauma wound or ulcer like this. So I agree to say it, but explain it more. Don't just give to the examiner and he will guess it. Because of what this patient is having diabetic septic foot. Okay?
But also not as a first differential, because it's painful, but this pain
No,
is
I said
Yeah, yeah.
syndrome, not septic foot. Diabetic foot syndrome, not septic foot. Which
Okay.
not septic
Diabetic foot syndrome. Okay,
syndrome.
you're right. Septic foot should be infection with
It could be
hypotension.
infection. It could be the neurology,
Yeah, bacteremia
vascular.
and all. Yeah, yes, you're right. So it's diabetic foot syndrome, but still, you miss the
Yes.
pathology.
Yes, I agree. Yes. Oh God.
Okay. Are you ready, Dr. Sarah? We'll start the second scenario.
okay.
Anyone want to ask before moving forward? Okay, here you go, Dr. Sarah.
Um, hello there. I'm Dr. Sarah, one of the doctor in service today. Is this Mr. James, 65 years old?
Yes, that's me.
Hi, Mr. James. We are here to discuss about your health condition. I will ask you some question, examine you, and then address your concern. Is this okay with you?
Yeah, good. Yeah.
So, Mr. James, can you please tell me what's brought you to here today?
Yeah, doctor, I've been feeling tired. Yeah.
Sorry for that. Sorry for that, Mr. James. I will try to do my best to help you. So, could you please tell me more about this tiredness since when he started?
I've been feeling tired for the past, I think, 8 months now. It's just getting worse. So I went to my GP, and it's what I should get it checked in the hospital. That's why I'm here.
Okay, I can understand. Do you notice anything that increased this tiredness you feel?
I'm not, no.
And nothing relieve it?
Possibly when I rest, I feel a bit better, but not so fantastic.
Okay, so it's comes and goes, and it's just you are tired all the day,
I'm tired always.
even without doing anything.
Yep.
So, did you notice anything you feel it beside this tiredness? Any complaint, other complaint?
No.
Just tiredness?
Mm,
So, Mr. James, can you tell me, please, do you have any high body temperature you feel?
no.
Uh, okay. There is no mumps or pumps everywhere, anywhere?
No notice any.
Okay. Do you notice any skin rash?
No, well, I've not noticed anything and anything in particular, but just some changes in my hand.
Hands?
Yep.
What about this? Please, can you tell me, please?
I just noticed some changes in my hand that possibly look like a rash. Yeah.
You mean the bottom of the dorsum? Where? Exactly where? Can you send the picture, please?
Yeah, sure I can.
Okay, thank you.
Hmm.
So, what about your weight?
Yes,
Any change in the weight?
yes, I've also lost weight, doctor.
Lost weight. How many kilo for how long, please?
Oh, I think I've lost. I have not really checked really, but I think my belt hole, I've changed. Yeah, and also my clothes is getting a bit bigger on me.
And for how long you noticed that you lost your weight?
About 4 months now.
4 months. Okay. Is it intentional or no?
No. Though my eating has not been fantastic as well.
So no change in your appetite. Appetite is good.
I've not been eating well as well.
You didn't eat well, or you eat
No,
well?
no, I don't eat well.
So you lost your appetite also, yeah?
Mm-hmm.
Okay, sorry for that. Okay, can I just ask you about this skin rash on your hand? Is it in both hands or just one?
Both.
Both hands. And it's since how long?
Hmm?
Since how long? When you notice this rash? Started
How long?
since
Okay, how long ago? It's been there all night in the last 7 months. Yeah,
and it's appear without disappearance or just comes and goes?
it comes and goes.
Did you notice anything that caused this rash appear?
Yeah, it comes during summer. It's been increasing during summer.
In summer, okay. And disappear in the other weathers in the winter and
I feel
cold
much
weather.
better since it's getting cold now. So I think it's getting a bit better.
Did you notice any rash anywhere in your face or on your neck or anywhere?
You can look at my face. I'm not quite sure I have any rash, but if you look at my face, possibly.
Can you send me a photo?
Oh, sure, I can.
Okay, please.
Yeah, post
Okay,
picture in the chat box.
okay. This is also since 4 months?
Same about the same time.
Okay, I understand. But no, in the neck, nothing, yeah?
I've not noticed anything like in my neck.
Okay, Mr. James, can you please tell me, do you have any disease? Should we worry about it?
Any what?
Disease diagnosed
No,
before, should we worry about
no,
it? You
no,
didn't take any medication?
no.
Show me your medication list, please.
I'm not on any medication.
Even over-the-counter medication?
No.
Okay. So, Mr. James, I will ask you some few questions. Do you have headache?
Headache? No,
Yeah. Blurred of vision?
no,
Okay. Do you have any neck swelling?
no.
Any weakness or feeling of numbness, tingling, or
Yes, I do have tingling in my hands and foot.
since how long?
I can't remember. It's been a while. It's been there for a while.
Before this
Yes,
tiredness or after?
yes, before the tiredness.
Okay. Do you have chest pain?
No.
Do you have cough?
Yes,
Coughing?
doctor.
Cough. Okay. Since how long?
Oh, I started coughing about a month ago.
1 month?
Yeah,
Okay. And it's wet or dry?
It was initially wet, but recently I noticed that I started coming out with phlegm.
With phlegm now?
Yeah,
But at the beginning it was dry, yeah?
it was dry at the beginning.
Okay, so and when it changed to wet?
So what?
It was dry when it changed to wet. Since how long?
Now
I mean,
it's coming out with phlegm, but it's more of like a salivary thing. Yeah, that's just
okay, saliva. Okay, just in last month or for how long this
1 month.
become wet?
1 month.
Okay.
I've been coughing for 1 month.
Do you have shortness of breath?
I've not noticed that, doctor.
While you're sleeping, you didn't notice any shortness of breath waking you from sleeping?
No,
Do you have any awareness of your heartbeat?
no,
Do you have any tummy pain?
no,
Difficulty of swallowing?
no,
Okay. Do you have any change in your bowel habit?
no,
Water work?
no,
No frothy urine, no change in color or amount?
no,
Do you have any joint swelling?
no.
No joint swelling at all.
Mm.
Okay. Okay. So no swelling, no pain in your joint. What about the pain?
What about?
Pain in your joint.
No,
Back pain.
no.
Okay. Okay. Do you notice that you feel thirst a lot? You want to go for water work a lot, or
No,
do you have hot or cold intolerance?
no,
Okay. So, can you tell me, please, do you have any surgery before?
no,
You have any history of traveling lately?
no.
Okay, I will ask you some few personal questions, if you don't mind. Are you a smoker?
Oh, yes, doctor.
How many cigarettes?
About 10 stick a day.
About
10 stick a day.
a day? For how long?
Oh, I've been smoking since a teenager when I was 15, I think. Yeah.
Okay, I highly recommended you to cut swelling and stop swelling because it will harm a lot of your health. If you need, we can refer you to smoking cessation clinic to help you regard this. Is that okay?
It's okay.
What about alcohol?
Oh, yeah, I take alcohol as well. But social, just weekend sometimes.
No drinking?
Mm.
There is?
There's what?
Okay, what about your job?
My job. I'm
What do
retired.
you do for
I'm
retired?
retired. Yep.
What you used to do before?
I was a teacher in the primary school.
Teacher, okay. Okay. So, may I examine you?
Oh, sure thing.
Okay, for general look, beside this brush, what else there is I can notice in general? Nothing?
Mm.
Okay, we'll start from the hands. I noticed that there is a rash over the dorsum of the hands, bilateral. What about the bulb? There is any pallor, cyanosis or something?
Yep. Palo. Yep. In the
There is
hand, no.
pallor.
Yep. There's no palo in the hand.
No pallor.
No.
Okay, what about pulse?
What about?
Pulse.
I didn't get that, please.
Your pulse, the pulse of the
Pulse. Okay,
patient.
the pulse. The pulse is regular, normal, regular.
No collapsing pulse.
Nipple and pulse.
Okay, no joint swellings anywhere or tenderness anywhere for joint?
Mm-mm.
Nothing. Sorry.
See.
Okay, and then the face, any pallor or jaundice in the eyes?
Palo, no jaundice.
Just there is a rash around the eyes, yeah?
Mm.
Okay, what about mouth? There is ulcer or something?
No.
Cyanosis, central cyanosis?
No.
And the neck, no GVB?
No.
I want to auscultate the chest. What about the chest?
No rash on the chest.
Not rash, I mean auscultation.
Auscultation,
Yeah,
normal findings. The chest.
yeah, chest
Oh,
normal.
yeah, just reduce breath sound
Where?
on the middle lung zone on the right.
Right middle?
Mm.
Right middle. Okay. What about the heart?
First and second at sound. No more.
No added sounds.
Mm-mm.
Lower limb, there is any joint or rash or something? Joint
No.
problem? Swelling? Edema?
No edema.
Okay. Okay, thank you.
You're welcome.
So, Mr. James, can you tell me please what's your concern?
So what exactly do I have?
I highly appreciate your concern, Mr. James. After asking you and examining you, there is a possibility what you have. But the first possibility for me, it's appear like you have a disease called dermatomyositis. Don't bother about the name. It just I will explain for you. This is a disease affecting the skin and your muscle also. It may cause you this tiredness, and I'm sorry to tell you this disease may associated with some hidden cancers, and for you maybe it's a lung cancer also. I'm sorry to tell you that.
Okay, doctor, do you mean are you saying trying to say I have cancer?
I'm sorry, Mr. James, but there is a possibility of that because your tiredness, you're losing weight, and there is a possibility to have this cancer. I'm sorry.
Okay.
Do you
So
have any other concern?
I'm just wondering, why do you think I've gotten this? Because I'm just concerned why.
About the cancer, you mean?
No, the whole thing, the name of the disease you mentioned, and then the cancer. Why do you think I might have gotten this?
This disease, it's some kind of disease that the defense system may attack other parts. The defense system responsible for defense our bodies may attack tissue in our bodies. That's why it may
2 minutes
cause
left.
like this. Like this, it will comes like there is a rash in your face and your hand, and also it may affect your muscle and you're feeling tiredness. And so, Mr. James, can you please? I want to examine something, please, if you don't mind.
Okay. Yeah.
I want to ask about the proximal myopathy. Is it positive or negative?
Positive.
Positive proximal myopathy. Okay.
Mm.
Okay, thank you.
Doctor, is this serious?
I'm sorry to tell you that it's serious condition. It's not that simple, but I will assure you that we will do our best to help you regarding this.
Okay. All right. Thank you, doctor.
Welcome.
Yeah, thank you.
Okay, welcome.
You
Start or
finished?
what?
Examiner questions, Dr. Ayula.
Okay. Can you present your findings?
36 years old gentleman came with fatigue since 8 months, associated with rash in his around the eyes and in the hand, and also complaining of that chronic cough that increased in the last 1 month. This is the positive thing, nothing else. Hello?
Yes, I can hear you.
Yeah, this is all. By examination, I found there is a cotton nodules in the hand, and also there is a rash around the eyes called actually I forget what's the name. And auscultation, the lung was showing there is a decreased air entry or diminished air entry in the middle zone of the right lung.
Okay, so what are your differentials? What do you think is going on?
My first differential diagnosis for this patient is dermatomyositis due to lung cancer.
Okay, other possible diagnosis? possible differentials?
Other possible differential, it will be another cancer anywhere, colon cancer, prostate cancer, but regarding this, there is no other symptoms. And hematological malignancies also, because he is old age and has tiredness and mild pallor. This is my differential.
Okay, so how are you going to manage these patients?
I'm regarding the investigation, we will request general or basic investigation regarding
Dr. Sarah,
CBC.
can you raise your sound, please? Because
Okay.
some doctors cannot hear you.
Okay, sorry. Basic investigation regarding CBC, CRB, ASR, and liver renal function test. We should do chest X-ray at the beginning, and then maybe we will need chest CT for him. And also we will need CKMB. It will be raised, and at the end maybe we will need EMG and muscle biopsy to confirm the dermatomyositis condition.
How you manage?
I will manage this patient non-pharmacological and pharmacological. Non-pharmacological education counseling, patient education and counseling, offer social occupational support if you need it. And pharmacological, we will do as a multidisciplinary team with the pulmonologist, rheumatologist, and social worker also, and it's according to stage of lung cancer, if it's need surgery or chemotherapy, and oncologist also, and the treatment will be according to the stage of lung cancer.
Okay. Thank you. Yeah. Well done. Thank you.
Welcome.
So just a few more questions before we go.
But regarding dermatomyositis, we should offer also prednisolone.
What?
Prednisolone, steroids.
Okay, I was just about asking you that what are the medications that you can use, and also the autoantibody that you're looking for, specifically in dermatomyositis.
Oh, صح. Autoantibodies, for dermatomyositis, there is anti-MI2 autoantibody, and it will be positive if it's the dermatomyositis.
Okay, what other antibodies will you also want to do?
Okay, we can also, and sometimes it will be ANA will be positive for maybe the patient, and also maybe antigen 1 sometimes be positive.
Okay, so could you say other skin manifestation that you're looking for in dermatomyositis?
Cotran plague that the patient have. We have Schawel sign in the neck and the shoulder. Periorbital region, this also patient have, I think it's called heliotrope, I think. Heliotrope rash around the periorbital. And also patient mostly will complain of photosensitivity. Mechanics hand also sometimes.
Okay.
It will be like rough skin. That's all I remember.
You talk about the Shaw sign on the chest?
Yeah, I already do. Shaw sign.
Shaw sign. Also, you can also see some telangiectasia.
Yeah, telangiectasia
as well in the nail fold.
Fingers.
Yes, and the fingers are the things that you can't see. Okay, but can you repeat your differentials again, please?
My first differential will be dermatomyositis due to lung carcinoma. My second differential will be another malignancies rather than lung cancer. like
I
blood and such?
mean the diagnosis of the patient, not the cause of the matter. I mean diagnosis, the differential diagnosis in this patient's presentation, fatigue, rash, and things like that.
Actually, the rash is specific for dermatomyositis. I couldn't think about anything else. That's why I'm doing differential for fatigue itself.
Mm,
Old male patient and with fatigue, so the top differential for me was the malignancies, hematological malignancies also,
okay,
and that's it. I can
okay,
find another differential actually.
okay. All right. Did you consider possibly of systemic lupus erythematosus in this patient? Is it a possibility?
Um, very, very low possibility because he is male and old age, and the systemic lupus will be at the young female patient.
Yeah, I agree with you, but
But
it's
still,
not
yeah,
it's not
maybe.
exclusively for those age, just common in those age group, not exclusively.
Yeah, sure. But
Yeah,
yeah, could be as a differential
is
also.
a differential, yeah. What about mixed connective tissue disease for him? I know you try to look out for every other thing.
Yes, yes, mixed
Yeah,
connective tissue.
connective tissue.
Okay, but regarding this, nothing else like
Yeah.
rheumatoid arthritis or
But I still think
sclerosis.
that
No.
these things should come up. Then, in
Okay,
terms of dermatomyositis, you can now start talking about other malignancies that you can try to look out for. But in this
okay,
patient, because of this presentation, the possible um, differential diagnosis of his condition, his presentation, okay, it could be all of these things that, yeah, that's what I think.
okay.
Okay, and well done. Okay, Dr. Bazin?
Yes, you can comment Dr. Ayula about what she missed, what she did.
Okay,
Yeah,
yeah,
the case now is known for all, I think. Dermatomyositis is clear.
yeah. It's quite
Yeah. Just comment
it's,
on her performance, then
yeah,
I will.
it's quite a common case, and I think you did well in the presentation and in the history taking. You did quite well in the history taking, but just for something I think you need to ask for. It's quite she said with do you ask for the history of skin rashes on the skin, but the history of skin tightness, just to look out for systemic sclerosis, skin tightness, change in the skin color could also be important here. It's quite good that you ask for history of headache in this patient, yeah, arthritis for him. So I think you covered basically most of the things I have done. Just like examination, you didn't have this patient for hair loss, which I think might be important in the patient that you're thinking of autoimmune um disease for. Okay, and then okay, you ask for medication in terms of looking for every other medication that can cause this fatigue and muscle weakness that the patient is having. So investigation wise too was good. Investigation wise too was good, honestly. I must say that you covered a lot of things. Just that the management, you skip the medical management of it. Did you talk about the steroid sparing agents? Using them.
About what?
Steroid. I remember you spoke about steroid. Then what about
No,
other?
no. I just
Yeah,
mentioned the steroids.
yeah. It's also important that we talk about that as well. And also, if the management of patient presenting with rash predominant, uh, dermatomyositis is different from those that are presenting with fatigue and every other thing, which I think is also important to speak about it. If the patient is more concerned about the skin sensitivity, hydroxychloroquine would be the best option. But if it's just about the myositis and things like that, then that's when you consider the steroid, the cyclophosphamide, the methotrexate, the steroid sparing agent, basically. Okay, then yeah, then screening for other form of cancers as well. The patient have lung cancer, possibly the possibility of a lung cancer is there, but it's also good to look out for other cancers which you mentioned in this patient. But before we go, do you know the poor prognosis factors of dermatomyositis? I mean, the poor prognostic factor. Hello, Dr. Sarah.
I have no idea actually. Hello, hello. I have no idea about the
Okay.
prognostic
Yeah,
factors.
there are some factors that are prognostic factor in dermatomyositis, and that include older age of presentation. It's worse in male. You know that most autoimmune diseases occur in female. So when a male has it, it's worse, as well as if it's an older patient like has. Then if you have underlying malignancies, of course, it will worsen the prognosis, in them. Then if they have anti-Jo autoimmune, that's why I asked you for other autoantibody that you want to check. And then we want to check for anti-MI2 and anti-Jo, which is more in polymyositis. But if it is dermatomyositis, they also have worse prognosis. And then if it's associated with anti-synthetase syndrome, which is a combination of arthritis, myositis, and inflammatory lung disease. That means if they start having the lung affectation as well, then you start talking about their worst prognosis. So basically age, sex, their presentation, and the autoimmune antibody. If you can find anti-Jo1 in them also, they have worse prognosis. So basically that is the stations. It's quite a common station, and I think you did well. Well done.
Thank
Yeah.
you.
Thank you,
Thank you.
Dr. Ayula. I will ask Dr. Sarah now why you mentioned very, very low, while you are saying it could be cancer.
Yeah, I
Sorry,
said it could be cancer.
SLE. No, SLE. It couldn't
Yeah,
be as. And anyway, don't say very, very low. There is possibility. As long
yeah,
as
still there is
patient is having autoimmune, don't be too much judgmental. Very, very low.
okay.
Okay, just say
Okay.
yeah, there is possibility. However, it's not high or even low. But very, very low means there is nothing. Anyway, the smoking as well, it's one of the risk factor here. You didn't mention while discussing with the examiner, he asked you, you didn't say in the history this patient is smoker. He's
You mean
significant. He has
when
significant
I
history.
present the case?
Yeah, yeah, yeah.
Ah, okay.
Okay, it's very
Okay.
important.
Yeah,
It's a
sure.
very significant history of smoking if this patient is smoking since teenager age. So it could be the
Okay.
reason even of the cancer, right? Either
Yeah, sure.
dermatomyositis or dermatomyositis complicating the cancer or cancer complicating dermatomyositis. But the cancer here might be related either to the disease or it might be related to the smoking.
Smoking.
Yeah.
Yeah, sure.
When you ask the patient, don't tell him if you have any disease. You tell me if you have
Okay.
any medical condition I should be aware of.
Okay.
Okay.
This is my
Because
first case to take, by the way.
no, I'm trying to correct the
Yeah, sure,
things.
sure. Thank you.
Yeah, but
Thank you.
as first time, perfect. Really, you did great.
Thank
You
you.
can do diagnosis. You rolled out, but I don't think if you roll out other connective tissue disease in this scenario. You ask about difficult swallowing.
I
You ask about,
Yeah,
but
I
don't.
also asked about the ulcers,
Yes, I
about
agree. Yes,
joints. He
but you
he
didn't ask
didn't.
about
He said negative.
stiffness. You said any joint swelling by name. Okay, don't
Swelling and
specify the
pain.
question. Okay, stiffness. Still, some patient will present with stiffness, and they will consider it not pain, not swelling.
Okay.
Okay, and
Okay.
whenever you ask about system, don't say it together you have any change of your water work amount or frequency. Not ask together. Ask them one by one, or you can ask in general. You have any change of your water work? Yes, doctor, or no. If you want to specify, don't say color, amount, frequency. He will answer you the last thing, which is the frequency, for example. If you want to
Okay.
ask them one by one. Okay. Apart from this, perfect, but try to put good differential. Don't say this is a case of dermatomyositis only. No, you have to think widely. Why this patient having this fatigue, and I should put fatigue with rash, with more differential. One of them SLE.
Actually,
Yeah,
yeah. Actually, I did differential for fatigue at the beginning, and then when
it's good.
she
It's good
said
to yeah.
the rash, I cut the dermatomyositis, and then I couldn't think about any
Yeah,
other.
it's okay. It's okay. The rash always they might bring a rash and they will tell you what is differential diagnosis. So the rash will be spot diagnosis for disease. But at least I can speak about rash with other presentation. So I will say, for example, rash in young patient, male or female, which is redness. I will think first of all about systemic lupus, but I can think also about erythema nodosum. I can think about myoderma gangrenosum. So I can put them as a differential initially Later on, I can say to the
Mhm.
examiner against that, against that, against that, because it will be away from the diagnosis. It's not conclusive or it's not a clue for this case, but I ruled it out by a question. Okay, try to put good differential because always they are judging on the differential diagnosis. Let's go to the
Okay.
fatigue. As you did, fatigue always relate it to the appetite or the weight. Sorry, not the appetite, the weight. If the patient is having loss of weight, this is mostly something dangerous like serious infection or connective tissue disease or cancer. Okay. However, if the patient is having fatigue along with weight gain, I'm talking about endocrinology issue like acromegaly or Cushing, polycystic ovarian or metabolic syndrome. Okay,
Hypothyroidism. Mhm.
sorry,
Hypothyroidism also.
hypothyroidism. So the definition will be different. So yeah, whenever you have fatigue, please ask about the other constitutional symptom because fatigue, one of the constitutional symptoms, you are analyzing them together. Fatigue, or feeling tired, or lumps or bumps, or high body temperature, or fever, or loss of weight, and appetite. So go further to the relevant, which is the constitutional symptom, and later on you can narrow your differential more. In this case, yes, it's one of the connective tissue disease, and you can proceed further thinking about the other differential what I mentioned, cancer, serious infection, or connective tissue disease. Okay,
Okay.
and the
Okay.
case here is clear regarding the spot diagnosis and the rash this patient is having. Well done, Dr. Sarah, as a first, as I said.
Thank you.
And let's open discussion. Anyone want to comment, to ask question? Dr. Ayula, you want to add anything else?
Oh, no, thank you. Well done.
Yeah, okay. It's a good criteria also to mention the poor prognosis or bad prognosis, prognostic factors. Whenever the patient or the disease presented in a different age, commonly it will be, for example, in young, if presented elderly, or if it presented in different gender, you can put it as a poor prognostic factor without thinking, or a typical symptom. By for any disease, you can put these manifestation as poor prognostic. A typical presentation, young, elderly patient, different gender. Okay, so you can just think without even you can mention without thinking. Okay. Anyone
Okay.
want to add any other comment or information? Is it clear for all? Okay. Thank you, Dr. Ayura and Dr. Sarah again. Thank you everyone for the attendance. Dr. Gabriel and everyone commented and the differential. It was good differential rate. I didn't read the differential. Dr. Gabriel, yes, he put the differential of the case. Polymyositis, dermatomyositis, photodermatitis, rosacea, contact dermatitis. But here, yes, it's likely dermatomyositis malignancy induced. Perfect. Thank you, everyone. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank